Hello and welcome to the 2024 Emory Division of Hospital Medicine Teaching Competition. This is our fourth virtual competition and seventh overall. I'm Moni, and I'm joined by the Amy to my Tina, or the Tina to my Amy, my effervescent co-host, Dr. Meredith Trubit. How are you this evening, MT?
Pretty good. How are you?
You know, I'm feeling a little lonely in this office today. So it's a new encounter for us. We usually are right across from each other.
Yeah, there's going to be absolutely no interpretation of your body language.
But I think you can read my face pretty well at this point. And my office is a steamy 76 degrees. It was ready for you today. But however, I think the exciting thing is we might get some squeals from Mighty Max Handler in the background. So I feel like we're in good position, potentially.
I mean, sure. He's sleeping right now, so and hopefully it stays that way.
He might he might interrupt us a little bit later if he wakes up. But all right, great. So this year we are lucky enough to have 5 esteemed judges. We have some folks you might recognize, and we've got people from all over the country. We've got Dr. Natalie Giles, who was formerly a faculty member here before she escaped to Washington, D.C. Just as the pandemic was taking off. She is now faculty at George Washington University in Washington, D.C., where she's a medical director at United Medical Center. We have Dr. Lauren Heidemann, who is the Director of Faculty Development at the University of Michigan Division of Hospital Medicine. We have Dr. Eric Howell, the esteemed CEO of SHM and friend of the Curb. Dr. Paul Williams, who is faculty at Penn State University and co-founder and co-host of the Curbsiders Internal Medicine podcast. And we have Dr. Shahnavaz, who is from the Emory Division of Gastroenterology and Hepatology. I hear that the Division of GI and Hepatology, they're looking to get some faculty development going, and so they're scoping it out. Okay, so we brought sexy back, guys. Things we do for no reason, part 2. We had it a couple years ago, very popular. Everyone's always asking for it, so we didn't, mess around with it. We brought it back this year for our theme. And as usual, I'd like to thank Dr. Lenny Feldman, who is one of the leads on that always lets us use that trademark. And interestingly, he's actually a big part of the reason this competition has kind of become a little bit more external with our judging. And also he's the inspiration for this next part. But yes, very grateful for Dr. Feldman. And one last piece of very exciting news that hopefully some of you already knew, but probably don't before we start. The stakes are even higher this year. Outside of the infamous teaching trophy currently and likely permanently housed at the VA, this year's winner will represent Emory in our first ever teaching invitational hosted by Emory that'll occur on May 7th. There's a flyer for that at the end. Get excited. Next slide. All right. Also, hopefully these rules are not new to our speakers. 8-minute talks with 2 minutes for questions after. The ability to answer questions does not, it should not affect your score. So keep that in mind, judges. It's only meant for learning and discussion purposes, because that's really what this evening is about. And for the 2-minute question period, members of the audience, please limit your questions to the chat box. That's what Meredith helps with, moderating the chat box. So we will hit mute all if y'all try to talk. So just put them in the chat, and we'll get through it, and it'll be a good time. It's usually what I like to call a warm hug going through that chat box. So, all right. And as far as the scoring goes, or sorry, your 8-minute time limit. Well, we don't have world-class orchestra, so we'll just cut you off. We also do not have Ryan Gosling to do an encore of I'm Just Ken. So you're just going to have to, roll with it. We'll just, have you stop. So, okay. With all of that housekeeping out of the way, next slide, please. We got our schedule of events. Got Dr. Jones, Dr. Umpierres, Dr. Muigai, Dr. Desai, Dr. Ajao, and Dr. Chikwava giving their talks. Next slide. All right. First up, we have Dr. Mike Jones. He's representing Emory University Hospital. Now, I feel bad about not remembering this about you, Mike, that you're from the UK, and then you majorly downgraded to New Jersey. I'm sorry about that. And then you trained at Emory and had the misfortune of having me as an attending for a little bit. And then I also didn't realize you're basically Forrest Gump with cycling. Like you've done a cross country cycle twice in 2013 and 2015. And then the other thing, now you don't get to see this because Haruka smartly picked the not funny picture. But he sent us a picture. Were you at space camp in the other picture?
I sure was. I space medicine, space, all things about the galaxy and stars. I love.
Awesome. So how old were you when you got to go to space camp?
That was probably 8 years old.
Okay, man, I feel like that was like when I was like looking at the stars every day and trying to memorize like the planets. Okay. All right. Well, without further ado, we've got Dr. Mike Jones, and his talk is to stress or not to stress.
All right. I will go ahead and share screen. Okay, can you guys see presentation? Getting some head nods. All right, so welcome to my talk titled To Stress or Not to Stress. We'll be discussing a thing that we do for no reason, that is ordering stress testing over coronary CTA in the evaluation of intermediate risk acute chest pain. On the agenda today, we'll be talking about the limitations of stress testing, benefits of coronary CTA, and based on that, my recommendations. So jumping right on in, limitations of stress testing. And what I hope to highlight is that when looking for obstructive disease or greater than 50% stenosis, these tests, stress testing, actually have limited sensitivity, specificity, and more importantly, when you look at non-obstructive disease or less than 50% stenosis, I think they're probably missing this diagnosis. And to highlight that first point, this is a table looking at the relative sensitivities, specificities of different stress modalities. And when we look at stress testing with imaging, we see that the pooled sensitivity, it's about 80 to 90%. Pooled specificity, 70 to 80%. That means that roughly 1 in 5 stress tests are falsely positive, falsely negative. And if we turn our attention to non-obstructive disease, we know that stress tests are designed for flow-limiting coronary stenosis. So non-obstructive disease, by definition, not really flow-limiting. I think stress testing might be missing these diagnoses. And I think this is a problem because there's good data to show almost 2/3 of future MI are coming from non-obstructive disease. And I think this table does a really good job of sort of highlighting that point. So this is the annual rate of death or MI following normal and abnormal stress testing. And if we look at the annual rate following a normal test across the stress testing modalities, it's about 1%. And initially I thought, not too bad, but 10 million patients are getting stress tests each year. 70% of these are read as normal. And so that means that 70,000 people each year are having MI or cardiac death after a normal stress test. And I think that's probably because they were missing non-obstructive disease. And so you might wonder, like I did, is there a better way? And as the talk suggests, I think coronary CTA might be that better way. Just a contrast CT looking at the coronary arteries. And as an aside, it's not coronary calcium scoring, separate test, separate talk, but very interesting. But for coronary CTA, I hope to show you that for obstructive disease, it performs better. For non-obstructive disease, there's a trend to better diagnosis of it. And there's pretty good data that using it does change management and improve outcomes. So coronary CTA for obstructive CAD, there's a pooled sensitivity, 98 to 99%, pooled specificity, 82 to 89%. And if we flash back to stress testing, we see that it performs better. And you might have heard of the PROMISE trial. I'd like to talk through that briefly just to highlight this trend towards better diagnosis of non-obstructive disease. So the PROMISE trial, multi-center RCT, looked at about 10,000 patients with intermediate risk chest pain, randomized them to functional stress testing versus coronary CTA, and had a primary composite endpoint listed here, death, MI, and a couple other things. Now, very busy slide, but bear with me. So this is a table of data from the PROMISE trial, and it is highlighting test findings over here on the left and the corresponding event rates as they relate to this endpoint down here. And on the left side of this whole table, we have coronary CTA. On the right side, we have functional stress testing. And I want to zoom in on what I found most interesting about this data, and it's the difference between these two tests in regards to normal and mildly abnormal, which was essentially defined as non-obstructive disease. And so if we look at the frequency for coronary CTA, we see that about 54% of the patients had a mildly abnormal test, 33% had a normal. If we look at the stress testing, hardly anyone had mildly abnormal results, just 10%, whereas almost everyone, 80%, had a normal test. And I think this is important because if we look at the event rates, we see that coronary CTA on the left is very clearly highlighting a difference between the mildly abnormal group and the normal, 3% and less than 1%. Whereas stress testing over here on the right, you can't really tell the difference. They're both 2%. And I think this is because coronary CTA over here on the left is probably picking up non-obstructive disease. And to show why that matters, I wanted to highlight the Scott Hart trial. So this was a prospective RCT, looked at about 4,000 patients, randomized them to standard care versus standard care and CTA in regards to this primary endpoint here. And the summary is that this trial basically found that using coronary CTA in addition to standard of care lowers the rate of composite endpoint at 5 years, statistically significant, not crossing the midline. And subsequent analysis pretty much showed it was driven by lowering the rate of non-fatal MI. And I think probably again, because it's picking up non-obstructive disease. And in addition to that, more people in the CTA group got started on preventative therapies, 20% versus 15% was statistically significant. Again, I think this is probably because it's picking up non-obstructive disease. And so what are the takeaways here? Coronary CTA, higher sensitivity, specificity for obstructive disease. There's a trend to better diagnosis of non-obstructive disease, and using it leads to better long-term outcomes by getting more people on preventative therapies and lowering the rate of non-fatal MI and coronary heart disease death. And this data was so convincing that my friends in the UK actually use this as the first-line test for intermediate risk chest pain. Here in the United States, we're not quite there yet, but as of 2021, the AHA-ACC now recommends stress testing or CTA for the evaluation of intermediate risk chest pain. Before it used to be just stress testing. And so I think we should be doing more CTA. There are some limitations though. So tachyarrhythmias, elevated BMI, age over 65, all going to limit the test characteristics of CTA. And then of course, if you believe in contrast in kidneys, that is of course a risk. And so based on all of this, what are my recommendations? So if you have a patient with intermediate risk chest pain, none of these limitations on the left here apply. Go ahead and order the coronary CTA. You'll end up not missing non-obstructive disease. You'll start more people on preventative therapies, and you'll improve 5-year outcomes. And that concludes my talk. Here are some of my references, and I will leave the visual abstract from the paper and answer any questions anyone might have.
So on the chat, lots of great jobs, obviously, which it was a really nice presentation. Lots of outstandings. Mohammed wanted to know your thoughts on like CTA costs as well as expertise of radiologists impacting like that decision.
Yeah, I think the expertise is like a really good point. The benefit of coronary CTA really depends on having the radiologists being, trained and being expert enough to read the study. So if your center doesn't have radiologists trained or with experience in coronary CTA, it's going to limit the benefit of them. Cost, I think there's a lot of data out there that's coming through that it's about the same as stress testing from what I could see, but if anyone out there has other information, definitely let me know.
There's just a lot more. I'll just keep reading some of the comments. Excellent work. That was out of this world, which I think was, a reference to your space maybe interest, or I'm hoping I'm getting to the pun. Also don't know if anyone caught Moni's earlier scoping pun, but that was pretty good for her. Eric said
actually-
thank you for that informative talk.
I did a pun. Like I seriously didn't realize it.
Oh yeah, when you were introducing our judge from GI, you said, and he's scoping it out.
Oh wow.
It like
So good at
endoscopy.
puns, and I don't even know it.
I know. Chill House, I'm not sure who that is. But someone at Grady, we adjusted our angina algorithm to guide providers away from nuclear medicine studies to cardiac CTA. Some CT scans are better than others and better handle tachycardia and high BMIs. And then one other question for you, Mike. Do you know anything about whether the radiation exposure is the same across like the nuclear med studies versus the CTs?
Yeah, there's actually really good data emerging from this. I think the actual article, Things We Do for No Reason, on this topic addresses that question. And the takeaway that I remember was that the coronary CTA over the course of people who are getting stress testing is actually less radiation than like the radio tracers that are being used for stress testing. So less radiation, I think, was the takeaway I saw.
Awesome.
I think, are we coming up on time? I believe we are.
Oh, and Monica just wanted you to know that you had 2 seconds to spare on your timing. So well done, Mike.
Awesome. All right. Okay, I think that's time for the questions. We'll move on to our next speaker. Wonderful. Dr. Adrian Umpieres from Grady. He is originally from Guayaquil in Ecuador and trained at Cook County. He's been with us since October of 23, but was faculty at the Medical College of Wisconsin for 10 years before that. His fun fact is that he has surfed in lakes. Didn't know you could do that. Lake Superior, Marquette, and then Lake Michigan, Sheboygan. And I'm not going to lie, the reason that I decided to read this fact is I just wanted to say the word Sheboygan. And then his walkout song is "The Passenger" by Iggy Pop. Can't say I'm too familiar with the Iggy Pop catalog. Yeah, no, I was telling the speakers ahead of time, this year's song selections have been like, I did not know a lot of them, so I lots to learn. And then one of the questions I've been asking this year is the piece of art that best represents your life. And he said Finite and Infinite Games by James Carse. Is that a book, I'm assuming?
Yes, that's a book.
Yeah, what's it about?
The way I interpret the book is about how, life structures your thoughts to be a finite game player. So everything is, like a seek and reward. And what the book teaches you is to be an infinite game player, that to do, things not because of the reward, but because you actually like playing the game. So I try to apply that into education, into medicine, into my personal life.
Awesome. All right. And so without further ado, we've got Give Me Something for the Pain.
Let me share my screen. Sorry, I'm a little technologically challenged here. For some reason, I can't. It doesn't give me here. Sadly, I heard a much better title that I regret not using, aka Tramadont, but too late. So my talk is about things we do for no reason. This is actually one of my biggest pet peeves with IV hydralazine for hypertension and midodrine. So the other reason I chose this topic is because actually one of my former residents wrote the paper, so it's a little bit of a sentimental attachment. So nothing to disclose. The objective of this talk is very simple, just understanding pain and its different types. Tramadol as an option, not really, and to actually win the competition, why not? So we're gonna start with a case presentation. So it's a typical Grady patient, a 74-year-old woman, admitted for COPD exacerbation. She has your most common past medical history: CKD, heart failure, type 2 diabetes, complicated by neuropathy, nephropathy, CAD, depression, and she's also a COPD on 2 liters supplemental too. You're the nocturnist on call, and you get a nice friendly call at 3 in the morning. So the patient is asking for something else for pain, as the acetaminophen did not work. And you went ahead and give the 74-year-old lady with a bunch of contraindications and a bunch of medications, nice tramadol. So we're going to take a pause here and talk about types of pain. So you have nociceptive pain, which can be divided into somatic or visceral, neuropathic, radicular, referred, psychogenic, or you can divide it into acute versus chronic. This is going to make sense later on the talk. So a little bit of the medication itself. So as we as hospitals know that management of acute pain is a common scenario. Tramadol is a synthetic central acting analgesic. It has an active metabolite that binds to the mu receptor, and isozyme to these 6 facilitates conversions. The problem with this enzyme is that there's several polymorphisms that can result in variation in gene expressions and affecting how the drug gets metabolized. So why you would think it might be helpful? So it's always perceived as a mild opioid. I don't know, maybe because it sounds like Tylenol, but also its binding affinity is less than 4,000-fold compared to morphine. There's a misperception that this medication has minimal withdrawal symptoms that lowers the chance of overdose. And I guess we also think about it because it sounds mild and there's always policing about, the more scary opioids, and for good reason. So why should be avoided? Like I said, the metabolism is unpredictable. It has a very complex pharmacology. There's several drug-drug interactions. And there's actually the same issues as what is considered the scary opioid. So there's chance of misuse, there's chance of dependence, there's always chance of respiratory depression, as well as neonatal withdrawal syndrome. I just put this picture here. I will not explain this because if I actually try to, I would probably take me 20 minutes and I by de facto lose the competition. But it's important to remember this part here, the CYP2D6, which converts the tramadol to the O-desmethyl tramadol, which is the metabolite, and it happens in the liver. So this is just a continuation of why it should be avoided. There's limited evidence in hospitalized patients. Most of the data that we use for tramadol was done in the outpatient realm, and there's very small studies. There's a lot of, from the American Geriatric Society, there's a lot of warning about tramadol being inappropriate in other patients, which tends to be the patients that have the most contraindications to most common non-opioid options. So just for examples, drugs that induce the CYP2D6 or inhibit them, so dexamethasone, rifampin to induce it or inhibit bupropion, fluoxetine, can impact the efficacy and the pharmacodynamics of the drug. And also it doubles the risk of a serotonin agent with medications that inhibit this history of epilepsy, renal failure, or prior traumatic brain injury. So what should we do instead? So first, determine what the nature of the pain is, the type. Consider other approaches, more local, topical, some options like physical therapy, especially in this patient with knee pain. If you see the medication prescribed for patients that have contraindications or you're concerned about drug interactions, consider deprescribing it. And if an opioid is needed, try to assess the risk of misuse and then do a limited trial based on CDC guidelines for acute pain management. So for recommendations, complete a pain assessment, find out the pain type, utilize your resources, your other modalities for pain control, and consider a multidisciplinary approach. This is just the same recommendations in a much better visual way of explaining them. But the message is avoid prescribing tramadol. So conclusions, it has an unpredictable therapeutic effect. There's several risks for adverse effects. There's lack of quality evidence in hospitalized patients. To tie this up back to our case, I'm just going to highlight that the patient has a past medical history of CKD, heart failure, and CAD, complex of knee pain, and he has several contraindications for non-opioid analgesics like NSAIDs. So consider other alternatives such as intraarticular injections, topical analgesics, and physical therapy. These are just my acknowledgements to the author, who was my resident, to Marianne and Dr. Gallagher for helping me with some suggestions, and to all my colleagues at Grady and Emory for making me feel welcome. Thank you.
Awesome. Great talk.
We actually, lots of yays and nice job. There's one comment, and you're welcome to address too. Carrie said, I'm so glad you're addressing this topic. One of my huge pet peeves too. And some of our clinicians don't even know it is an opioid. I think they might confuse it with Toradol. And then a bunch of fantastics, amazings, nice jobs, great talks. Hooray.
Representing.
Yep. Paul asks, you mentioned deprescribing. Do you mean doing this for someone on tramadol chronically, like as an outpatient, I think?
Well, I would say if you're going to prescribe, if you're concerned about this medication, what I try to do is I try to look in their primary care doctors or whoever is prescribing this medication, and to assess if there's a true reason, if there's any other avenues being exhausted. If that's the only option and the patient is taking it without complications, I would continue it. But I usually try my best, not with these medications, with other ones like Plavix or aspirin for primary prevention, things like that. They're trying to find a reason. I think it's just good practice to just not take everything as face value and just question everything.
I'm actually going to jump in and ask a question for myself. You mentioned at the beginning that this is your pet peeve also with hydralazine for like hypertension. I feel like from a medical education standpoint, the residents, at least in like the last few years that I've been teaching, are really like starting to nail the hydralazine part of it. So I'm curious, have you compared like tramadol to hydralazine in those like two different situations of why you may not want to use?
I have not. I try to, when I'm on teaching teams, when I used to do this more often in my prior job, I used to have a set of expectations. And one of them was to, analyze every medication, every intervention that we do and, put some thought into it. And whenever they wanted to prescribe tramadol, we will go into the spiel of why and review the other medications. So I guess I try to give people leeway and free will, but there's certain things that they have to explain to me. IV hydralazine, one of them, midodrine, another one, and use of tramadol.
Awesome. There's a lot more like well done, great jobs, great talk, amazing. There's no other questions right now. If anyone has one, now would be a great time to put it in.
Carrie.
Yeah, Carrie's comment is, I also try to avoid Percocet since I've had many patients when I did palliative care take accidental overdoses from the Tylenol component from the Percocets.
Awesome.
And, yeah.
I know that that was a practice pattern I had to break very early in my attending career. Like within the first year, I think I had a patient like had a seizure outside the VA when I was a resident after downing a bunch of tramadol. So definitely high yield for all of us. All right, we're getting ready for our next one. I'm going to throw in a fun fact. No. All right. Dr. Inya Mugai is representing Midtown. She is from Kenya and trained at New York Presbyterian. She's been with us since 2020. So when I saw her fun fact, I immediately collapsed because it said a 70.3 Ironman championship in 2023. So I thought to myself, is this miles? Is this meters? Is this inches? Because I really hope it's inches. So let's get to the bottom. What 70.3? What does that mean exactly?
So it's a total distance you do between the swimming, the biking, and the run. So it's 90 miles on the bike, half a marathon, 30 miles on the run, and a 2-mile swim in open water.
Okay. Yeah. Definitely the collapsing still stands. Anyway, all right. So, and her walkout song is Rush by Ira Starr, and her talk is Mission Impossible. Cue the theme song.
All right. So hospitals should prescribe methadone for opioid withdrawal. Mission Impossible. So I distributed the survey to a group of hospitals and understanding why they do not prescribe methadone for opioid use disorder, and more specifically for withdrawals during hospital stays. I got 28 respondents and 1 specialist input. So 32% said it was due to lack of addiction training, and methadone prescribing protocols. 18% said concerns about potential complications and side effects. 4% said preference for other pharmacological interventions. 39% said patient's adherence and follow-up after discharge. 7% said limited time and resources for comprehensive opioid withdrawal management, and 0% said other. So a picture is worth 1,000 words, and I'm going to be addressing the large pieces of the pie. 100,000 people died of an medications for opioid use disorder have the potential to reduce overdose deaths by approximately 30% over a 12-month period. It also decreases acute care utilization for opioid-related problems and presents a great opportunity to initiate opioid use disorder treatment. So 39% said this was their reason. Did you know that patients started on methadone are more than twice as likely to present to an outpatient clinic after discharge? By initiating methadone, we improve our trust between ourselves and our patients and decrease the chances of them using substances while in the hospital. It also decreases the chances of them signing out AMA. Did you know that people who have opioid use disorder have increased risk of overdose death during life transitions? So say from prison to home because they lose their tolerance. So it stands to reason that hospitalized patients are at the same risk for opioid overdose after being hospitalized for days to weeks without regular use of opioids. So regardless of the patient's desire or ability to continue it, we should initiate methadone to prevent withdrawals as a way to maintain opioid tolerance. Thereby, we reduce the risk of opioid-related overdose deaths after they're discharged. There's also a 3-day rule that now allows us to prescribe methadone to those who are newly started to hold them over until they report to a clinic. Outpatient follow-up should be facilitated with the help of social workers. Teamwork makes the dream work. And lastly, remember to prescribe naloxone and discuss harm reduction as part of the overdose prevention strategy. So 32% expressed lack of addiction, training, and prescribing protocols. So methadone is safe. It's been used for years. It's safe and effective if it's used as prescribed and titrated accordingly. We start by assessing the patient for the risk of opioid withdrawal. Signs and symptoms to look for would be like resting pulse rate, GI upset, sweating, tremor, restlessness, yawning, pupil size, irritability. And because methadone is a full opioid agonist, it can be initiated before withdrawal develops. So we don't need to obtain a clinical opioid withdrawal score. It's also recommended to offer other adjunctive medications in addition to opioid agonist therapy to mitigate other withdrawal symptoms. Another important advantage of methadone is that due to its analgesic long-acting properties, it can be given as split dosing to treat both acute pain and withdrawals. So this is just a quick breakdown of how to prescribe methadone while in the hospital. You'd start at 20 to 30 milligrams per day and increase by 10 milligrams every 4 hours for withdrawals or cravings. Day 2, you'd start with day 1's dose and again, increase by 10 milligrams every 4 hours for withdrawals and cravings and keep going like that. Something to observe though, this guide was primarily done for patients who used pills or heroin. So this is based on those specific population of patients. Patients who use fentanyl commonly need higher doses and faster titration. So consultation to in-house specialists can then be done, especially if you're rapidly titrating or going beyond the 40 milligram dose per day. Make sure to stay updated on guidelines as this is always changing. Another reassuring thing, it is legal to prescribe methadone in the inpatient setting. So 18% said complications with concerns with potential complications or side effects. So concern number 1, QTC prolongation can lead to torsades. We always check EKGs in patients anyway, but they recommend for people who have high risk factors like electrolyte abnormality, structural heart disease, impaired liver, that you want to especially check an EKG in those patients. QTC prolongation also only occurs at higher doses, like greater than 100 milligrams per day, and also if they're on other QT prolonging medications. If it remains greater than 500, then you can then discuss risks and benefits and maybe consider something else like buprenorphine. Concern number 2, methadone leads to, due to its pharmacology, it leads to concerns about safety, but it is safe and effective when titrated correctly. Concern number 3, levels can increase or decrease in the setting of CYP3A4 inhibitors, but these drug interactions are not contraindications, and we can work closely with our pharmacists to guide titration of the drug by reviewing other medications that patients may be on. So this was from the acute pain specialist, Dr. Foster Whedon. His personal preference is Suboxone, but he noted providers are uncomfortable prescribing it and it is harder to secure outpatient follow-up. So back to methadone. Primary issues he expressed is insurance, follow-up, and readiness for the patient to go into recovery, and they need a lot of counseling and psychosocial support after discharge that the patients rarely have. But he definitely emphasized having a discharge plan and engaging social workers. So to help make this mission completely possible, please answer the following question. Which of the following do you believe would be the most effective strategy for encouraging hospitals to prescribe methadone for inpatient opioid withdrawal? A, specialized training and education. B, implementing clinical practice guidelines or protocols. C, offering consultation or support from addiction medicine specialists. D, increasing awareness of the benefits of methadone treatment for opioid withdrawal. I'll just give you a second there. Mission accomplished.
All right.
Oh, sweet. All right. Awesome. Thank you.
Just a lot of people answering like C from the question, and then lots of great jobs. So Deepa asks, main issue that people have been running into is like the follow-up for these patients. We don't get more than 20 pills during discharge. How do patients continue to get these meds? I totally agree. Methadone can be used to help patients with pain, and patients are not groggy. They can be functional while using, but there seems to be practical issues.
Yeah, I think that was the biggest concern. And similarly with with Dr. Foster, I think the emphasis was getting the social workers on board. So kind of starting that process early to try find them clinics. And if a patient doesn't have a clinic, like within, close to the proximity of where they live, then trying or discussing other options, grouping off and bringing the next best option. So it's definitely like a teamwork affair when we're planning for discharge.
And then Carrie kind of just added to that, so I'm just going to repeat that comment. Not only does Emory not have addiction consults available in patients, it's very difficult getting them outpatient follow-up, even with social work assistance. And then Paul's question, what about hospitalized patients not interested in recovery? That was my next question. Would you still opt for methadone or another pharmacologically cleaner full agonist?
So it's got to be a discussion with the patient. If they're not interested, I think that would make it harder to prescribe. It was recommended though, if they are in withdrawals, that it is a safer way to manage the withdrawal, even if when they leave, they have no intention of continuing.
Yeah, I mean, I'm going to just comment because we're lucky, Moni and I work at the VA. So like we have our own methadone clinic through the VA. So it's pretty seamless from when we want to get someone started. But yeah, I have heard, from other people that the linkage to care has been a big barrier, at least here. I think other cities tend to have maybe a little bit better like availability. Couple other comments in the chat. Pain medicine at Midtown has an addiction specialist who rounds once or twice per week. At least they did as of fall, from David. And then Carrie, it's good to know that Grady has a free Suboxone clinic. Great talk, an important topic to bring up. And then a lot of other great talks in the chat in there too. And then one last question. How are the GI side effects that you see in patients on methadone?
On methadone, I'm not sure. It was more the side effects from withdrawals. I'd have to look into that and see what the GI side effects would be on methadone.
Okay. And I think that's time for the Q&A. Thanks, guys.
Thank you so much. Awesome talk. All right. Next up, we've got Dr. Kevin Desai representing Emory St. Joe's. He is a native ATLian, specifically the Marietta area. He trained at Wellstar Kennestone up in Marietta. He's been with the division since 2019, so right before the world blew up. He is an avid tennis player, which I should be excited about, but I have a lot of rackets. I don't use them. And then what is Red Rising about? You said it is it doesn't represent your life, fair, but it's a fantasy series. Like, what kind of fantasy are we talking? Is there like a little bit of sci-fi in there? Or is there all like unicorns? Like, what's that about?
Sure. Yeah. It takes place in the future. It's just it's an adventure of a lifetime. It's got multiple series to it. It's just like a new technology in the world Like I like these stories where the author comes up with a world, like a brand new world that's totally new. Um, and this author does the same thing. He just creates a new world that it just kind of gives you a different perspective on life, and it's you kind of get lost in this world. So it's an adventure. Um, and I'm like reading the last book now, so that's why I put it in the email.
Oh, awesome. Yeah, and I didn't mean to stress you out about a song, a walkout song, but that, like I said, that was like the most stressful question for people. So, um, anyway, coming off the heels of Dune, this sounds very intriguing. So I might have to explore. But enough about that. Here is Dr. Desai with intensifying antihypertensives on discharge. Favorite topic.
Yep. Okay. Perfect. So intensifying antihypertensive on discharge. So I'm going to just give you a clinical scenario, and then we will Quentin Tarantino this backwards to the recommendations. So it's a 63-year-old male, past medical history of hypertension, COPD, diabetes, hyperlipidemia, came in with shortness of breath and wheezing and admitted for a COPD exacerbation, started on steroids. Incidentally, he takes hydrochlorothiazide and lisinopril for the last 3 years and has been very compliant. His pressure has been perfect, near perfect at his primary care visit office, at his PCP visits. But throughout the hospital stay, his blood pressure has been around 148 all the way up to 175 systolic. By day 4, dyspnea is resolved. He feels well. We're cleared for discharge, but the nurse calls you and says the pressure is 156/91. So what do we do about that? What do we do now? I think it's important that we first look at some of the assumptions that hospitalists make about blood pressure to understand this problem. So one is hospitalists extrapolate outpatient blood pressure and use them to say this is what inpatient blood pressure and outpatient blood pressure is the same, because patients have stressors on the outpatient side, so they would also have, it would be very similar. Hospitalists also, due to fragmentation of care and poor communication, can change chronic disease management. So essentially, hospitalists are trained similarly to primary care physicians. Some of us were primary care physicians and vice versa. So this almost seems like another touch point for patients in the healthcare system. They see their PCP every 3 to 6 months, and then every now and then they come and see us. So we're just doing our job to control their pressure, which is why we crank it up sometimes if it's high. We also believe that blood pressure Q4 gives us this really unique opportunity to say, well, we have a little bit more data. Patients, it's a one-time blood pressure monitor at the outpatient clinic, whereas we have it all day for multiple days. So maybe we have a better idea of what the real pressure is. And then nurses, consultants, and patients, because patients are going to look at that Dynamed or Dynamap and be like, what are you doing about this blood pressure? I'm not sure if I'm ready to go home today. So we get a lot of pressure, and these pressures can also cause hospitalists to crank up blood pressure medications. So why do hospitalists increase blood pressure medications on discharge? One is we lack guidelines. There's really no clear guidelines on whether we should increase them or decrease them or hold them. So we kind of do our own thing. We also don't have a system to monitor the quality of our care after discharge. Unless they're a discharge readmission, they bounce back because of something we did in regard to blood pressure, we have no idea. It's out of sight, out of mind once they leave. So this is a study from the VHA in 2018 that of 15,000 adults, 65% of them had normal, well-controlled pressure. Of those patients, 11% of them had their blood pressure intensified on discharge. This means that we actually do it. 11% of us are actually changing blood pressure medications during their inpatient stay. Another retrospective cohort said that patients discharged on intensified regimens did not have better blood pressure control with the 1-year follow-up, and they actually had higher rates of MI and acute kidney injury. And when specifically looking at patients with well-controlled pre-hospitalization blood pressure, the group that had their regimen intensified experienced a higher risk of adverse events at 30 days and CV events at 1 year. So in some cases, we're doing a little bit of harm, even though we're just trying to get those pressure numbers to look better. So when is intensifying hypertensive medications indicated? When should we do this? So you'll see in those studies, you'll see that they didn't talk about patients admitted for cardiac reasons like CHF, acute stroke, CAD. They just admitted patients for other issues. So that's one indication to raise control pressure in the inpatient setting. We also have patients that had pre-existing ambulatory hypertension, so they weren't controlling their pressure on the outside, and that's another indication that we should look a little bit closer at it. And we also got to make sure people are taking their medications. I think one of the biggest assumptions that physicians make is that we prescribe medication and patients take it. So I think we need to assess whether they're actually taking it before we start making changes. What should you do instead? So don't react and treat single elevation blood pressure readings, but pay attention to the trend, risk factors, diagnosis. So pay close attention to overall pressure during the inpatient stay. And ask yourself, could there be another reason why the patient has high blood pressure? All these issues like anxiety, pain, urinary retention, these issues in the ambulatory setting cause increased blood pressure. So focus on treating those issues, and that actually may solve your blood pressure problem as opposed to just giving the patient another medication or going up on the same medication. Pay attention to medications used in the inpatient setting. So IV fluids, NSAIDs, steroids. In this particular case, in the case that I presented earlier, the patient was on IV steroids, which likely transiently increased the blood pressure. Consider decreasing the frequency of vital signs in patients who remain stable. So, or on the flip side, if you're treating them for pain or you're treating them for an issue that can raise their pressure, consider not checking their blood pressure because you know it's going to be high because you're dealing with something else that's transiently causing blood pressure. And consider a warm handoff with the PCP with a discussion about the need for intensification, and do it as a team with them. So it's not so split. PCP does something and we do something. So in summary, do not routinely intensify blood pressure regimens in patients admitted for non-cardiac causes. So if they come in for a non-cardiac cause and their pressure is good on the outside, don't intensify. When available, review their blood pressure in the ambulatory setting, look at their last PCP note. They have the vitals in those notes, and educate the patient in case they look at that Dynamap and they're like, yo, where's my blood pressure medication? You can just say, hey, if I overtreat you, this could really be bad for you. So just really educate patients on the risk of overtreatment and recognize clinical circumstances where inpatient changes to blood pressure medication regimens are warranted. So if I had to really summarize this in just a few seconds, I would say if the patient comes in for non-cardiac causes and has good pre-ambulatory pressures, do not do anything with that blood pressure on discharge, even if it can get up to 160, 170 systolic. And if they do come in for cardiac causes like CHF, or they come in for like CAD, or it's a heart cause and their pressure is high, you can kind of take it in your own. I think if studies have shown that controlling blood pressure in coronary patients improves their overall mortality. So that would be a good indication. So it's mainly let the pressure go, unless you really feel strongly. And that's it. Thanks, Moni, for having me.
Thank you. Awesome talk.
Lots of great talks coming in. While I'm waiting for some questions, I'm going to shamelessly plug Moni and I's first episode that we did with Curbsiders was also inpatient hypertension. And Kevin, you hit all the highlights in 8 minutes. So if anyone wants a longer presentation hitting all those same highlights, episode 310.
I will say that the benefit of listening to that whole episode are Dr. Noble Malick's incredible jokes. So
Yeah.
if you listen for one reason, it would be that.
Yeah. Did you guys have any questions for me?
I am waiting for some in the chat. There's lots of great talks. Very practical.
What do you guys do? I mean, do you guys have patterns of adjusting blood pressure medication up or down in the inpatient setting?
Personally, I feel like what you said is is my practice now. Trying not to intensify medications as much as possible, which has been interesting, especially in the last couple of years with the increase in the heart failure realm. I feel like that's kind of been its like separate category, but yeah. I do have one question from Allie. Do you have any recommendations on how to handle the pressure from nursing staff? I do find they really want to treat the numbers and they get very nervous when blood pressure is up around that 170, 180 range.
Yeah, I mean, what I do is it's education. I think if nursing staff's concerned, those are valid. I always want my nurses to be concerned because they're my eyes and my ears. So if they're concerned, I always take it seriously, but I use it as an opportunity to educate them on what we're doing or what could be causing the blood pressure to go up. Is able the patient's on steroids or we're doing this or the patient's on fluids. And the more we teach them, the more they'll come back and be like, hey, the patient's blood pressure is high, but the patient's on IV fluids. Maybe we can stop them if it's not indicated. So I like that kind of feedback from the nursing since they're a valuable part of our team. So I think it's just a chance to educate them on what you're doing about it. And it's okay to do nothing.
So now I have a bunch of questions. So the next one is any targeted analysis on certain blood pressure medications being more harmful than others if the blood pressure regimen isn't it's intensified.
So that it wasn't in the article that I read, and I don't think I can responsibly answer this question. I know there's so many different blood pressure medications out there. We all have our back pocket blood pressure medications that we love, ones that have been good for us. So I think that would be a whole more than an 8-minute presentation going through these blood pressure medications and how they're different. Even hydralazine alone could be a whole 8-minute presentation in itself.
And I think the last question I got on here is from Eric. Do you extrapolate holding some other new meds, such as like lipid lowering beyond like just their blood pressure meds?
Sure. I don't like holding home medications. I very rarely hold home medications unless there's a contraindication to the home meds. So usually I will continue all of them. I'll try to continue them unless it's a reason why they got brought in. But if I can keep everything the same in the outpatient setting, I will. It also gives you an opportunity to identify if a medication is doing harm. If you continue it and you don't know better, you can see an interaction while you're in the hospital, maybe an LFT bump. So I always like continuing them because I'm trying to replicate them on the outside as much as I can on the inpatient side. So I don't hold them if I can avoid it.
Awesome. And I think that's our 2 minutes.
We have Dr. Rukia Jao representing the Atlanta VA. She's originally from Lagos, Nigeria. She trained at Morehouse and joined the VA here back in July of this past year. She was a nurse for 16 years in her former life, and the piece of art that best represents her life is Portrait of Christ by prodigy Akin Kramarik. Hopefully I said that right. What's that about, Ruki? Like, what's the book about? Is it a book? I'm assuming it's a book.
No, it's actually a painting.
Oh,
Yeah, it's a painting by the child prodigy, and she actually made that painting like when she was like 8 years old. And I thought it was just an excellent depiction of Christ, and has been a real pillar in terms of what I always reference and go to when I just want to sort of get back to being focusing on something to help me distress or, meditate. I always reference that painting, and I have a replica of it in my home.
that is literally the only piece of art, like painting, in this whole thing. So I'm glad I clarified. Awesome. All right. Well, we're ready for your talk. Fecal occult blood testing in hospital bias patients with upper GI bleed.
Okay, so I need to share my screen. Is that coming across okay?
No. There we go.
That's good.
Yeah. Are you on multiple monitors?
One monitor.
Okay. I can't remember how to get rid of this view. Say, hit use slideshow. Yeah, there you go.
Okay. Okay, hi, as she said, my name is Rukayat Ajao, and with contribution from my partner, Carolyn Coleman, I'll be talking about fecal alcohol blood testing in hospitalized patients. I have three main learning objectives. One is, what is fecal alcohol blood testing, how it works, what are the indications and utility of FOBT, and also what are the limitations and utility specifically in hospitalized patients. So fecal alcohol blood test, FOBT, as we know, essentially two main types of testing, which is the guaiac-based testing and the fecal immunochemical testing, which is essentially a fecal smear test that's used to detect the presence of blood. For the guaiac-based, essentially, as we see, hemoglobin can be broken down to the heme group and the globin chain and undergoes further action by bacteria in the GI and broken down to porphyrins, peptides, amino acids. And for the guaiac-based testing, it's actually able to pick up the presence of the hemoglobin or the heme group as well, heme acting as a pseudo peroxidase activity causing an oxidation, which can be detected by the actual guaiac, which is a chromogen, and a positive test would be blue. For the FIT FOBT, it detects the presence of hemoglobin in the stool via qualitative and quantitative methods. And for the second learning objective, so the indications, so you can see the main indication for FOBT stems from the U.S. Preventative Service Task Force and the American College of Gastroenterology that recommended as one of the methods for colorectal cancer screening in average risk, and I emphasize average risk populations. And this stems from a testing from research that dates back to the 1990s, which shows that there was some benefit with fecal alcohol blood testing, as it was able to decrease the mortality rate of patients who were tested. The other indication, which is developed as more of an off-label use of FOBT, which is used to detect alcohol GI bleed, especially in patients with anemia, where there's no overt bleeding and may have evidence of iron deficiency anemia. So utility of it as stated as a screening tool decreases mortality from colorectal cancer. I think it's worth noting that the specificity and sensitivity of this screening tool is low. And it's also inexpensive. It can be performed by any healthcare professional, and there are really no risk, complications, or any side effects to it. So, why not? A positive test shows that there's likely blood in the stool, with the following exceptions. As you can see, because the FOBT has such a low specificity, it's limited by high false positives, some of them being ingested blood from extraintestinal sources, intestinal mucosal inflammation, medications, and raw fruits and vegetables. So essentially, swallowing blood can be one of the things that can easily result in a false positive, or eating certain meats as well, because it picks up that heme. Intestinal mucosal inflammation, so your patients with GERD can also, trigger a false positive. Medications as well have been implicated, specifically medications like the low molecular weight heparin, SSRIs, aspirin, and Plavix. And that also has resulted in false positive, as well as raw fruits and vegetables, because of the presence of the plant peroxidase, which sort of mimics heme. Now, the interesting thing about these limitations is that as a requirement for the test, you're supposed to help mitigate the causing these false positives by holding medications for 7 days prior to actually testing. And as well as limiting foods or avoiding foods that can cause the false positives by avoiding them for at least 3 days prior to testing, which is, as you can see, is not necessarily feasible in a hospitalized setting. In the outpatient settings, let's just say everything was done properly, all medications were held as they should. In the outpatient setting, it's been shown that 37 to 53% of patients go on to have a subsequent negative colonoscopy, and 79 to 89% of them go on to have a subsequent negative EGD, which essentially speaks to the low specificity of the FOBT. In the inpatient setting, research has shown that 65% of the patients were on at least one medication that affected the validity of the FOBT. And I can say everybody knows, for one, DVT prophylaxis, low molecular weight heparin alone, which would be unreasonable to hold something like that for 7 days prior to testing. Also shows that within the inpatient setting, that those who actually underwent the fecal alcohol blood testing, 98% of them showed no evidence that there were any dietary restrictions that were implemented. So essentially, in most of the patients who actually undergo the testing, it shows that it's not even a valid test to begin with, not to mention, whether it's actually a false, whether it's actually a positive or a negative result, and what to do with those results. A negative test tells you nothing, well, nothing clinically relevant. And that's because FOBT is also riddled by limitations with high false negatives. And this speaks to the low sensitivity of the test. Its research has shown that it's unreliable, especially in detecting upper GI bleed in patients. And this is because the hemoglobin undergoes digestion, prior to even getting down to where it's being passed out. And then it shows that it may not pick up the actual hemoglobin or the byproducts because of the prior digestion. The FIT testing specifically has an even higher false negative than the guac-based. And also it's limited by high false negatives from the ingestion of vitamin C containing products as well, due to the antioxidant effect. Hospitalized patients, it's shown that 42% of them with negative tests were found to have endoscopically identifiable causes of iron deficiency anemia. And in the study showed that with hospitalized patients, even though that they tested negative, they still went on to get the GI evaluation with EGD, and essentially the results were ignored. And majority of the patients suspected with high suspicion of GI bleed still underwent the endoscopic evaluation. So essentially, when the patient got a negative test, from what the statistics show and the research show, it was essentially ignored, and it wasn't even adhered to as it should be. So another limitation for the FOBT is due to user error. So for example, this is an actual sample of the guac-based testing. And as you can see, you've got 3 different smears here. And if you were to look at it, which results would you think would be positive, and which ones would you think would be negative, just based on your personal interpretation? Okay, I'll give you a second there. And as you can see, for the first slide here, this is a negative smear. And for this other 2 slides, also a negative smear here, and these are positive. And what's interesting is that with this 3rd slide, the positive has a much, much deeper hue compared to this testing sample here and this sample here, but they're all considered positive. So it's really limited by the user interpretation of what they think would be considered a positive smear or not, or whether they feel like it's appropriate enough to call it a positive result based on the degree and the intensity of the actual the blue in the guac testing. The 3rd objective, so essentially, is what are the limitations, utility of FOBT in hospitalized patients? As stated earlier, it's limited by high false positive, high false negatives, and also difficult to read the results. And so with the high false positives, essentially, if it were to be acted upon in a hospitalized setting, it could result in potentially unnecessary procedures, increased length of stay, which negates the benefit of it being inexpensive. And then you've got the high false negatives, which, if acted upon, could result in potentially untreated GI bleed. And that could also, result in, increased length of stay, and can also result in actual patient harm. So I think, based on the studies that has been done in the past, a lot of clinicians are astute in, disregarding the negative test result of the fecal alcohol blood test. And of course, there's also difficult to read results with potential user error. So essentially, in summary, when it comes to fecal alcohol blood testing, especially in hospitalized patients, I would say this is definitely something that we do for no reason. It has absolutely no clinical benefit, especially in hospitalized patients, due to the degree of the limitations, with it being, having such a low sensitivity, such a low specificity, even in the outpatient setting. And within the inpatient setting, it's just not practical. It's not practical to hold Plavix for patients. It's not practical to hold your DVT prophylaxis for 7 days. And it serves no benefit. We basically don't necessarily act upon that information. So I would say it's definitely one of the testing that should just be eliminated from the actual, and a lot of times you find it in order sets. It should just be eliminated as a testing for hospitalized patients altogether. Any questions? Thank you.
I forgot to unmute. I'm sorry. Lots of great jobs coming in, Ricky. I'm going to try not to be biased like I usually am on here, but way to rep the VA. Lots of fantastic jobs.
I think, hold on one second for the judges. Just make sure you hit yes if for the overtime piece. I did go slightly over.
Great talk and slides. Informative. Well, hey, Amy. Awesome job. Loved your talk.
Fan favorite, Amy Miller. Yeah, I wish we weren't muting all because I just need the Amy Miller laugh right now, Meredith.
I can't recreate that. All right. From Dan, have you had success convincing GI fellows not to ask for the hemoccult result before seeing the patients?
On the contrary, GI, they wonder why it was ordered most of the times, and they'll tell you, well, it's negative, but we're still going to do the EGD, or it's a useless test. So they'll be the first ones to advocate that it has no clinical utility.
And I think the follow-up question to that is, or the ER for that matter. That's who I've seen as the primary offender.
Yeah, that's a different conversation to be had. I think it's definitely worth creating that awareness, that it's not necessary. If anything, it could, increase length of stay, which is, what we're not looking for, and it can actually, potentially cause harm if it's not acted upon, based on a negative result.
Practical talk, great talk. And from Dr. Akwe, do you even still have the strips available in our hospitals? I feel like we do have them.
It's available.
I feel like you have to like track down the reagent or whatever. That was always like the mission in residency. Like you had to find which cupboard they were hidden in. It was very Mission Impossible-ish, not to be a callback.
Yeah.
All right. I think since we were over, I think we are probably out of time. So we will go to our last presentation. Our last presenter of the evening is Dr. Bunyai Chikwafa. He's representing St. Joe's. He is going to be, he is originally from Zimbabwe and has done the tour to the United States. Went to the University of Nebraska and then Meharry, and then he went to Arizona for residency. So, man, that is quite the circle. I thought I had been around the States. And so you said you're an avid traveler. What's your favorite place you visited?
That would be Barcelona. Barcelona was amazing.
Okay. And then, so when I saw your answer to the piece of art that best describes your life, I had some questions because your response was the Count of Monte Cristo. And as you all know, those are some interesting themes. So please explain.
Well, the Count of Monte Cristo, the movie in 2003 by Jim Caviezel, I just think was extraordinary. For those who are not familiar with it, it's a kind of a rags to riches, going after the people who had wronged you and falsely imprisoned you and coming up on top. So it's kind of an underdog story with a great ending. And I love great endings, just like everybody else, I would think.
Fair, because, stepping back, the themes that I recall because of that great ABC show Revenge were exile and revenge, as evidenced by the title. So anyway, anyway, very excited for your talk. Trending ammonia levels during the treatment of hepatic encephalopathy. Take it away.
All right. Let's get the screen shared. All right, so let's go ahead and get started. So the topic, of course, is trending ammonia levels in the management of hepatic encephalopathy. The objectives we're going to go through today is listed here. Describe what hepatic encephalopathy is, describe the relationship between ammonia and the levels between hepatic encephalopathy and the levels of ammonia, and a quick overview of treatment, and to answer the question posed. So we'll go ahead and start with the first two, and start by defining what hepatic encephalopathy is. So every time you define what hepatic encephalopathy is, you always want to make sure you include the fact that it's reversible and that there's cirrhosis involved, and that you have some neuropsychiatric abnormalities and accumulation of the ammonia. So how exactly does the ammonia accumulate? Looking at this animation here, you have increase in ammonia from the gut. This is from when you ingest foods that increase your ammonia levels. It gets absorbed into the hepatic circulatory system. The liver usually has a responsibility of processing that ammonia into urea and getting that excreted out of the body. But when it doesn't do that, the ammonia levels increase and they go to the head. And once they get to the brain, there's certain effects that they do that cause the neurological effects that we see. These are mainly described by astrocyte swelling. So through the blood-brain barrier, the ammonia gets into the brain, increases the astrocyte to increase in size and swell up, and hence more ammonia goes through. The mitochondria of the astrocyte is actually responsible for processing this ammonia and kind of neutralizing it in the brain. What ammonia also does is it increases the inhibitory pathway by activating the GABA pathway. So that's why you see the patients are more lethargic. And in addition to that, it decreases the excitatory pathway. So their patients become kind of very non-responsive and very lethargic. Also, it activates the microglia through the elevated levels of ammonia, lactate, and neurosteroids, and the glutamate. And these activated microglia increase neurotransmission dysfunction. So what are the staging in the hepatic encephalopathy? You mainly have the 4 stages as outlined above, and it goes anywhere from mild confusion to lethargy to increase in coordination and recumbency with other issues that are occurring as well, as you can see over here. When you get up to stage 4, you can get up to coma and death, as well as seizures starting in stage 3. So addressing what the ammonia levels in relation to hepatic encephalopathy would be. So in a study done at the Cleveland Clinic in 2003, they did a study where they compared ammonia levels in venous blood and arterial blood with the degree of hepatic encephalopathy. And they did have a positive correlation to the degree of hepatic encephalopathy based on that initial level of ammonia. Unfortunately, what confused their study a little bit was the fact that you have these outliers here that are patients who can go up to all the way up to grade 4 hepatic encephalopathy, but they do have a normal ammonia. So that begged the question, do we have to measure ammonia in the treatment of hepatic encephalopathy, given that we have these outliers? So another study that was done at the University of South Carolina in 2005 to 2013, where they looked at 121 patients who were receiving lactulose in the first 48 hours and compared their level of ammonia after that 48 hours. Here you can see that with the low R value of 0.0026, there was a low correlation between the level of ammonia with the dose of lactulose. But this was actually occurring while the patients were recovering. In the same study, they did they plotted this this curve of showing when patients were being treated for hepatic encephalopathy between days 0 to 12 and the percentage of resolution. Resolution was getting back to stage 0 or being completely normal. So here there was no significant difference between patients who had ammonia levels obtained versus patients who did not have ammonia levels obtained in the percentage of hepatic encephalopathy resolution. More so, they also then plotted the percentage of hepatic encephalopathy resolution compared to what their ammonia levels were at this day of resolution. So you can tell here with the red being high levels and the blue being low levels, we had patients on day 6, for example, who had 70 to 80% resolution of hepatic encephalopathy, but their ammonia levels were still elevated. So that also then kind of put that question out there, do we still have to measure ammonia levels while we're treating hepatic encephalopathy? So even though we talked about ammonia, there are other things that do contribute to hepatic encephalopathy. These factors include several options. So when we look at the liver, if you have a TIPS procedure, you have at a higher risk of developing hepatic encephalopathy. GI, if you have a GI bleed, or you have SBP, you're at a higher risk of hepatic encephalopathy. Yeah, if your oxygen is low or your PCO2 is high, you have a higher possibility. And here, if you have AKI and electrolyte derangements, your risks of developing hepatic encephalopathy are elevated. So moving on to our objectives, a quick overview on treatment. The mainstay on the on treatment is trying to reduce the ammonia levels. We do this over here by altering the enteric bacterial flora to reduce mainly the production and absorption of the ammonia. And here by using lactulose and rifaximin, we also reduce the absorption. We also do sometimes include some neuromodulators, that's the flumazenil, and we also increase synthesis of glutamate, which in turn reduces the ammonia by giving zinc, L-aspartate, and L-othenin, and the rest of them. So, answering the question, is it necessary to measure the levels of ammonia in the treatment of hepatic encephalopathy? So studies have shown that there is a correlation between ammonia and the degree of hepatic encephalopathy. However, some patients with high-grade hepatic encephalopathy have low ammonia. So this would count against measuring ammonia levels. There is no correlation between the dose of lactulose and the level of ammonia in the treatment of patients with hepatic encephalopathy. So even if you measure it, what you do, for example, by giving more lactulose, would not correlate in correcting that ammonia level. There's no significant difference in the rate of hepatic encephalopathy resolution when ammonia levels are checked versus if they're not. And ultimately, there are patients who did have resolution of the hepatic encephalopathy regardless of what the ammonia levels were, with some patients having high ammonia levels. So in conclusion, we should not check ammonia levels when treating hepatic encephalopathy.
Thank you so much. And judges, was a little over time, so make sure you note that in your scoring sheets.
Those are some of my
Awesome.
references, and if you have any questions.
I do have questions already in the chat, which is thrilling. Deepa wants to know, how do you conclude that confusion is due to hepatic encephalopathy when ammonia level is normal?
So going back to the definition, the initial definition of what the hepatic encephalopathy is, when we think that it has to be reversible and in the setting of cirrhosis. So sometimes in the setting of cirrhosis, you might get a normal ammonia level, but that doesn't rule out hepatic encephalopathy. So as long as you rule out any primary brain pathology, the the advice is to start treating for hepatic encephalopathy and just start monitoring clinically.
And then I think the other question she had is, do you trend ammonia levels?
Sorry?
Do you trend ammonia levels?
In that case, no, you shouldn't trend ammonia level.
Lots of great talks, lots of compliments, wonderful, very informative. Deepa, thanks you for answering her questions. Were you doing all of the inking like live while you were presenting?
Yes.
Oh, sweet.
That's really hard. It reminded me of Audrey's presentation from, I think now 2 years ago, from Midtown.
Yeah. Awesome. Man, the chat never fails, Meredith. Every year I say it, but every year it's a warm hug. You just feel good about things. You just feel good about everyone you're working with. It just every year never fails.
Yep.
And
John
now
Vasquez says
what's
it's
that?
like picture pages,
It
but now you
really
can continue.
What do you say?
It's like picture pages.
All right. So judges, please make sure that you go through your scoring sheets. If there's any changes you'd like to make those. And now I will just kind of begin the stall. Monica, if we could get up, forget where we would be on the presentation, whatever's right after his slide. Before I get to the thoughts from Dan, I'm going to do some quick acknowledgements. First and foremost, to our admin staff. There's a slide for this later, but I just want to make sure I don't forget. Just Monica and the team, just every year, there's no way this happens without them, and I cannot say thank you enough to their hard work. Our judges, everyone, Eric, Lauren, Natalie, Paul, Nikrad, just so grateful that you guys were able to hop on, especially some of the folks that I sort of tackled via text, if you will, somewhat last minute. And then to my effervescent co-host, Dr. Trubit, always a good time. And then Harika for always making the slides super pretty for between our speakers. Eric Bacon, who is always a bit of a content consultant, but this year also, I duped him into helping us with the scoring sheets. So thank you so much for that. The subcommittee for once again fielding all those emails, just always all hands on deck. I really appreciate it. And then, it's always my favorite night of the year. So it's always a good time for the division. Had a bunch of people on. I think we hit about 74. I imagine there's like some watch parties. So we probably got kind of to our normal the last few years, which has been 80 to 90. So I imagine with just like the watch parties that happen with people still on service, we probably hit those numbers again. I will point out the National Championship of Sports Illustrated in my background. Go Blue. And then I think that's all I had to say. So I was going to open it up to Dan, if there's anything he would like to say before we keep going.
Thanks for a terrific competition. Yeah, I'm always blown away by these talks, and I admire the courage of the presenters to present with a gastroenterologist on the judging staff. Yeah, great work. So yeah, and to Moni and Meredith, yeah, great work hosting this. Yeah, again, this is one of the highlights of our year, and I learned so much from these talks. Yeah, it's humbling to see how well we teach in 8 minutes. Yeah, so again, terrific night.
And then I was wondering if the judges had anything to say. If you don't, that's totally fine. But if any of you had anything to say, I would like to hear your thoughts.
I was actually typing that. Oh, sorry, go ahead.
Oh, sorry. No, I'm Nick Rod. Thank you, everyone. I really enjoyed it. I learned a lot, both from the topics and also from the format of this competition. So I really appreciate that, Dr. Amin inviting me, and I'm sure I took a lot for my division. Thank you.
I just put in chat what I was going to say, which is I've been always blown away by talks like this. I like being a part of it. educational program or universities, because I feel like I get so much more than I give just by even showing up. So thank you for the opportunity, and congratulations to all the presenters. You all did really, really well.
Great.
Thank you all for having me. It's great to be back part of the Emory family that just keeps continuing to give. And thanks for wonderful hosts and wonderful presenters. I learned from each and every one. So thanks again.
Hi, everyone. I'm Lauren Heidemann from Michigan. This is my first year here, and it's been such a pleasure. And like everybody else, I've learned so much. And this is just such a cool competition to have within your division. I wish we had something like this at Michigan. May try to mimic this at my institution as well. So thank you again for inviting me.
Always good to have you, Lauren. Very, very grateful. And if you need any, pointers, let me know. Before we get to our winner, Meredith, what would your piece of art that best represents your life be?
I thought about this for a long time today. And it's funny, I don't remember on whose, but you were talking about not having a whole lot of like paintings, but I was like, right now my life is very surreal. And so one of my favorite artists is Dolly. And I feel like on a block, that would be where I feel like my life is right now.
Wonderful. So I have a couple, and I don't have any art because I always was bad at going through museums. This one will surprise nobody who knows me even a little. Never Have I Ever on Netflix. If you want to know what Moni's vibe was in high school, watch that show. Like, didn't make the same poor life choices as the main character, but that energy, definitely me. And then outside of that, I mean, I don't know. I feel like that's like the best like young Moni, and then like adult Moni, I don't know. Probably some Kelly Clarkson album, obviously. I don't know. Okay. Well, I think Monica said we have a winner. So would you mind letting us know? This is a surprise to everybody. Wonderful. Mike Jones. For copyright reasons, I will not play your song, but know that it's playing in my head. Awesome. And this breaks the Midtown and VA dynasties, respectively, actually. It's the first time. So, I guess we're going to have to unbolt the trophy from the VA. It's okay. It's okay. Things are all good things. But congratulations, Mike. Awesome talk. Learned a ton.
Thank you, everyone. Yeah, such a pleasure to present here. And thank you, everyone, for listening and putting all this together. It was really fun to give a talk here.
Great. And then we have a couple things that housekeeping things real quick. So Mike will be representing Emory in the first ever teaching invitational hosted by Emory. That was a workshop title, by the way. Tuesday, May 7th at 5:30 p.m. on Zoom, just like always. The other institutions are listed. Mike, we're gonna win this thing. It's gonna happen. So excited that this will happen. Hope every one of you comes to join us on that night as well. Very excited to finally get this thing. We've been talking about it for a couple years, so I'm glad it's finally getting off the ground. And then the last piece, one more slide. If you could, this is 4 questions, guys, so it should take you less than 2 minutes. If you do a quick feedback survey just about the content this evening, would be greatly appreciated. And then I will let you guys get to your evening, and we are ahead of schedule, so you get some time back in your evening. Very exciting. But yeah, good seeing some friendly faces that I hadn't seen in a while. Natalie, Lauren, Eric will be seeing you in about a month. Excited about that. Paul, always fun. See you on Slack. And Nikrad, thank you so much for joining us from the division of GI. Paul, you're remarkably silent here. Did you not have anything to add?
Oh, no, I was going to echo what everybody else said, and then we sort of transitioned away. But yeah, I think it's just the commitment to education is remarkable, and I appreciate being invited. This was a lot of fun, a lot of great talks.
Awesome. Thank you so much, Paul. Appreciate it. All right. If you have the QR code and you're submitting it, awesome. Otherwise, it's been really good. Thank you all again for coming. What a great year. And, please come and support Mike in a couple months. We will have an invite out soon so that it is in your calendars. Thank you and good night.